when we try to preserve our own ergonomic safety, what we do is we end up increasing risk to the patient. And so all of those things should be balanced, and how products are designed or incorporated into a culture should look at every one of those things in order to kind of reduce all of that workaround process that naturally happens because staff is just trying to find a more efficient and safer way for which they work.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
On this week's episode of First Case, we're speaking with David Gomez, nurse anesthetist and CEO of Infinitus Medical. And Chris, last week you and I talked about patient positioning, and really we only got to discuss the quote-unquote basics, right? Supine, prone, lateral. But we put our patients into a whole lot more positions than that. And today we're going to focus solely on Trendelenburg positioning. And I know it's your favorite, right?
It is, and it's a little scary. And we put a new fear of God in you after talking to David. But what I hope is that our listeners today will take what they learned from him, take it back to the huddle that we talked about last season, and really get some education out there, because it's going to be everybody's responsibility to make sure that we're safe in so many ways, as we're about to learn.
Absolutely. So hang on to your safety straps. We will be right back with David Gomez.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is David Gomez, nurse anesthetist and CEO of Infinitus Medical. David, thank you so much for joining us today.
Thank you so much, and thank you for the opportunity and consideration to join you guys once again.
Oh my gosh, yes, absolutely. You are definitely a longtime friend, and you have been a part of our show really, I think, since the very beginning. If you weren't our first vendor spotlight, I think you were one of the first vendor spotlights that we did back in the day in 2021 when we launched the First Case podcast. I encourage all of you listening to check out his vendor spotlight. It's entitled Patient Positioning Without the Pain, Evolving Patient Positioning for Both Patients and Staff, if you really want to get even more in-depth discussion on our topic today. David, I absolutely have to say that you are very passionate about this topic. So let's get started with our conversation and let you go ahead and tell everyone just a little bit about yourself.
Well, yeah, again, I'm a nurse anesthetist. I've been a nurse anesthetist for over 20 years. In that time, like everyone else sitting at the head of the bed, we sit there and we watch everything in the operating room, and we see what works, what doesn't work, where things can be improved. And this is where a lot of clinical innovators can kind of come into this space of seeing and identifying a problem that, hopefully they can solve. And that's exactly what we did. We started a company and started designing products that really focused on the processes rather than just the positioning and just throwing something on a table and making everyone kind of figure out a way to use it.
Well, it's really cool. And I see you at Expo and at other conferences and vendor shows. And it's always neat to come talk to you and see how you're innovating and what is going on. And really what we want to dive into today is that why question. Trendelenburg positioning, we see it a lot. It's something that, while it's a unique position and it presents a unique set of challenges for the patient, for anesthesia, for perioperative staff in general, we're still positioning our patients in this position very frequently. But to start at the beginning so that we make sure everyone really understands what we're talking about, why don't we just explain what is Trendelenburg and when are we normally seeing that position for our patients?
Yeah, well, ever since we started kind of doing more laparoscopic processes, laparoscopic surgeries. And then obviously there's standard laparoscopy, and then there's robotics and that like, and kind of every hybrid in between. The purpose of Trendelenburg originally had started out as a means to increase patients' blood pressures when they were in stroke. And that's kind of fallen out of, when they're having hemorrhagic issues. And so to kind of stabilize their pressures, or if their blood pressures were low, we would bring their feet back up. And again, that's kind of fallen out of favor if you look at the literature. But in terms of how it's used in surgery, essentially, is it's using gravity for the same reasons, but instead of, bringing blood from the periphery into the central, what we're doing in Trendelenburg during these procedures is we're putting patients head down, so all their internal organs move up towards the head, cephalad. So that way we could open up the space and see everything we need to through the keyhole. That's what we call laparoscopy. So there's a benefit to that. There's also some drawbacks associated with the positioning and the degree of positioning that people are wanting to go into. And that's where things really start to break down when you don't kind of understand what's at stake.
That's such a great way to put it. And I think our patients really don't understand that when they are put on the operative table and they are laid on their back, that they don't stay that way. We try to use everything in our purview to be able to see the anatomy as clearly as possible. And so, you mentioned that sometimes we don't do it the right way. And, I think most of the time, what exactly, David, are we doing wrong when we're putting patients in Trendelenburg?
Well, there's not necessarily wrong, though we do see things out in the field that are a bit alarming from time to time, and it's all cultural, right? But, when we position our patients, whether it's for Trendelenburg or any other position that we use, it's really based on a series of processes. And those processes can vary from institution to institution based on the tools they either have or don't have. There can be issues associated with how we do it, the steps in which we do it, the utilization of staff. This has to do with patient size. This has to do with all kinds of things. This also has to do with surgeons who believe that 45 degrees and full head down is take it to the max is the way to do. But, we can discuss some of the issues with all the research that's come out there, and more is not better. It's actually less is better. Again, there's no wrong way. There's so many different products out there, but, you want to make sure you choose products that kind of guide a highly reliable process from start to finish, right? A lot of people have always used traditionally foam, for example, and there's bean bags and there's head and neck systems. We can't use shoulder systems anymore, and we can go into that. But it's really about focusing on what happens to the patient when they get in the room. And that's everything from how we position and how all of those processes impact the different roles in the operating room. One of the things that we focused on, for example, was the airway, right? It's because people don't want to lift their patients with a sheet because they have to physically lift them off these foam pads, or they'll drag and they'll rip and they'll tear. And then they'll position them patients down further for lithotomy and expect anesthesia to reach. And that's an imbalance. That's one of the things that we sought to change in this industry, because when we try to preserve our own ergonomic safety, what we do is we end up increasing risk to the patient. And so all of those things should be balanced, and how products are designed or incorporated into a culture should look at every one of those things in order to kind of reduce all of that workaround process that naturally happens because staff is just trying to find a more efficient and safer way for which they work.
Right. And it's all about perspective, right? I'm an educator. And when I first teach my surgical technology students about positioning, the first thing we make them do is take turns being the patient. And so we put them on the table and we put them in these different positions, especially Trendelenburg, so that they can feel exactly what we do to airplane a table, to put the head down, so that they understand that their patients who have no control over their own physical body are going to be put in these positions, and they can feel how scary it can be. And that gives them that unique perspective of, how safe we need to make this process for this patient. And then, to have also needing to protect and control their airway the entire time, that just adds an entire different layer to that. So perspective is everything, right?
Yeah, you're right, Chris. And it's amazing when we go out to conferences or we go into, facilities and we demonstrate the systems. You'd really be surprised how many staff members, even surgeons, have never actually been put in the position. And so a lot of the time we'll put them in position and because we want them to feel safe, right? Because we want them to feel what the patient feels, to your point. And you'd be surprised at you'd get them and you'll start moving them down. And within 5, 15, 20 seconds, they're like, get me out.
Yeah.
Because it's very uncomfortable for them because, they're just not used to being and losing that amount of control. And the other part that plays into that is once the patient's in these positions, we're also, as providers, understanding all of these things, we have to be advocates as well because, there's times where, if they want to be taken out of their position in 15 to 20 seconds or they can't tolerate any more than a minute, imagine being in that position for hours on end, right? And, we were recently called to a facility where there was an injury and they were asking us for some guidance. And one of the things that we found, which is actually a few things that we found, and this kind of went into the anesthesia conference that I attended that kind of fell into this too, is they had a patient that had a very catastrophic compartment syndrome of the arm. And the patient will probably never use his arm again, unfortunately, fasciotomies and the whole 9 yards. But when you go in and look at these types of situations, and it was very catastrophic for everyone involved, even the staff and all of that kind of stuff. But, one of the things that came up was the patient had been in essentially 45 degrees for almost 10 hours. And no one had ever said, hey, this is too long. Can we level out? Because the problem with hierarchies in the operating room is, we're all patient advocates, right? But there's this hierarchy, and sometimes, we've all worked with difficult folks, right? And
that's an understatement.
There and you say, hey, this patient's on my lap. Can we, finish his procedure, or can we reduce the amount of Trendelenburg? They're afraid of getting yelled at from a surgeon perspective, and this is not picking on surgeons, but these are cultural things that happen. But one of the things that we found during this situation was not only that, because you can position a patient to the best of your ability and do everything right, but it's degree and duration, right? The longer you're in those positions with greater degrees, greater shearing pressures, all those types of things, they all kind of accumulate over time that can increase those risks. And one of the things that we found during this situation is, and this was from a CRNA conference that I went to, is there's been a change in how we monitor blood pressure. In the old days, we do it every 5 minutes, for example. And what they found through all this research is there's some swings between the 2 and the 5 minute phase that can actually have some changes in morbidity and mortality afterwards. So they want tighter blood pressure control. So as a consequence, now we're running blood pressure cuffs every 2 minutes, sometimes 3 minutes, to try to do this. So if you can imagine a patient being in that position for that duration of time, having both arms tucked, and now you're running a blood pressure cuff, and we know how those things take, and those blood pressure.
Yeah, they hurt.
Time, right?
Yeah.
And now you're doing it every 2 minutes for that amount of time, right? That was one of the contributing factors where across the street at the other facility, they were doing ERAS procedures. And so instead of using blood pressure cuffs, they're using the little finger cuffs and or an A-line to look at CVV monitoring. CVV monitoring, because a lot of our patients are going to ERAS, and these all come into play with positioning. They're using these little finger cuffs, but had they been using those finger cuffs, they would have probably picked up on more perfusion derangements in that patient's arms over time to see that there was something there, and obviously would have reduced the risk of that blood pressure cuff, constantly going off here in the nerve bundle. So all of these things have to be kind of understood with degree and duration and what we use as everyday tools to determine if there's increased risk.
All right. So you've mentioned all sorts of things that I want to get into more detail on. So you've talked about degree. You've talked about duration. You've mentioned shear. You've mentioned tucked arms, like all of these things that show up in Trendelenburg positioning that are vital that we get right so that we avoid things like the patient you're talking about now. So let's start with degree of Trendelenburg, because I know that we've seen patients turned all the way up on their head. And I also know that you've talked before about research saying that that degree of Trendelenburg is not as necessary as some people think it is. So why don't you tell us about the degree of Trendelenburg and what research tells us is safe and what is best?
Yeah. So, if you look at different literature, there's Trendelenburg and then there's steep Trendelenburg. Some literature says anything greater than 20 degrees is considered steep. Most people say 30 to 45 degrees. I don't think it's ever clinically useful to be in 45 degrees. There's no benefit. There's actually a lot of research that says that it increases surgical time as well as increases bleeding by almost 50%.
Wow.
So,
that's a lot.
what I can do is I put some notes and stuff together here, to kind of go over some stuff as I was looking at the most current research. And I can send that over to you if you guys ever want to put that in the addendum so people can.
I can add it as a file to this episode. Absolutely. So that would be great.
So when we look at that, but some of the research this morning shows that we can get away with way less. And sometimes even, let's see here. This, for example, this study was done a few years ago, and they did patients that were, larger patients. And what they found is they had a mean of only 16 degrees. And so they put it between 14 and 18 degrees total. And this was done blindly. What they did is they used a clinometer, essentially something you can download on your iPhone. And it looks at angles, right? And so what they were doing is they were blindly putting their iPhones or iPads on the table and measuring the degree of duration, but not letting the surgeon know what was done. And, one of the ways that you can actually look at this too, and we used to do this at one of the facilities I used to work at. I was on the anesthesia committee for robotic safety. And so what we would do is we would always go full Trendelenburg, up until the organs moved and everything was visualized inside, that everything was out of the way. And then what we would do is attenuate or increase the head back up into a space where we lessen the degree of Trendelenburg, but the organs are still moved out of the way, because it's not like they're going to pop out of play. So there are some mitigation processes that we can do when we do these. We always want to test to the max we think we're going to go, just so we can look at once the patient's positioned. We can look at their, stability and how secure they are. And then once those organs move out of the way, once they get the camera in, then we can attenuate that before we dock the robot. So that's one way of reducing that. There was also another study, again, I can put this out there, that showed basically the same thing, that a mean was around 18 degrees, even in high BMI patients, with no increase in surgical time. And obviously the benefits related to that, because once you start going in these extreme gravity dependent positions, you get everything from airway edema, ocular edema, potential blindness, alopecia. There's a whole host of things that go up of risk with the degree that we're putting ours in. And, even all the new literature on, intraocular perfusion and intraocular pressure injuries that are greatly mitigated if we don't go over 25. And I will tell you, and I know this is long-winded and I'll stop, but there's a lot of institutions, unfortunately, either through injury and or research in their own institutions, that have their own institutional maxes that they do. A lot of our customer accounts will do only 27 to 28 absolutely as a max, and will never go greater than that because of all the research and or potential injuries that they've had that have set their culture to just abiding by some of these rules that are more beneficial to the patient.
Well, and thank goodness that the research is out there and is so current, because it is changing the practice. So, we used to just throw you head down as much as possible and get that bowel out of the way. You talked about edema, but we've also talked about, good grief, that extreme case of shearing and that devastating consequences and the fasciotomies that are going to have to occur. But, we do have to tuck. And of course, I'm getting the visual of the non-permeable covers that we put on these operative tables, and I think about all of the movement and the sheets that we use and things of that nature. But where are we most, I think, susceptible to shearing in our patients? And what kinds of injuries are you seeing that are most related to Trendelenburg as far as skin injuries go to our patients?
Yeah, there's, some folks that say that their products may not cause erythema or red skin. The problem with the erythema is there's a million reasons for erythema. There's heat, there's drugs, there's all kinds of things. So the causative issues that we see of redness when we move our patients after the procedure and check their back, that stuff goes away over time, unless you've been on on something hard or something like that. One of the things that people don't account, say, for instance, I see more shearing injuries from people lifting with sheets, because that sheet bundles and they have to physically lift. And what that does is it creates creases on the back. And when they lay them back down, they're laying on all these creases where we don't do any of that. So that's one thing. But another thing that people don't really think about is gravity shifts, right? We're talking about Trendelenburg, but what about colorectal procedures where we're, head down and then rotated? So picture using a draw sheet. If we're using a draw sheet and you look at AORN standards about draw sheets, they say, we shouldn't use them unless we absolutely have to because of all these risks of compartment syndromes and impacts to IV access and all those types of things. But, picture yourself laying on a draw sheet and you're essentially using the patient's weight in order to tuck that draw sheet back under the patient in order to use that weight to secure the arms. And it has to be really tight, especially in larger patients, because we're not using the things that we should, bariatric extenders, most of the time to support those patients' arms off the sides of the table. We're just letting them kind of hang and which is always a bad thing. But now if you rotate that patient, think about it. As you rotate that patient and that patient's laying on that sheet is going to tighten based on gravity shifting. And that tight is going to end up becoming like a tourniquet. And that's going to increase totally the risk of compartment syndrome, because now if you're laying to one side, you're going to have gravity dependent edema formation. Natural edema formation is going to, the longer we do anesthesia, plus that, because now we're going to have all this leaky fluid compartments. And so, but if the arm continues to grow based on edema and that pressure has nowhere to go but in, because now the sheets are too tucked tight and they're rotated laterally, that's where you're going to end up increasing your risk for compartment syndromes and stuff like that. And then you can get compartment syndromes if that sheet's just, say, for instance, right behind the wrist where a peripheral hand IV is. And, you got fluid coming in and then that back pressure builds up and then you rupture the vessel and then the fluid's slowly leaking. And the thing is we're not picking up on fluid derangements as much as we used to because we're running low flow states because of ERAS procedures. We're not giving as much fluid as we used to.
Right.
So some people may not even realize if they've been running a low drip because we pre-hydrated these patients under ERAS protocols and we're only running basic drips and or all these other ERAS, opioid stuff. And this kind of goes, I know Melanie gave this speech a couple weeks ago about opioid techniques and anesthesia to reduce them. All of these things really come into play when we don't understand positioning and the risk associated with everything that we do naturally. And then you've got shear related to patients, who may migrate during procedures because systems may elongate or tear, but then they're actually sliding. And all patients, what people don't realize is when you're going in Trendelenburg, it's like Jello, right? Or the back of your skin. I always tell people to just move the skin on the back of their hand. All patients are going to have 1 to 2 to 3, 4 inches, even more of adipose elasticity and skin elasticity before they stop, with all the mechanisms of friction and pads across the chest and all those types of things. So when you do that, as long as those patients aren't moving once they settle in their final position, that's fine. You shouldn't really have any shear after that.
Goodness. And you think about our geriatric population too, right? Where their skin is even less padded.
More fragile.
More fragile.
You even hate taking paper tape off those patients.
I know.
Yeah. You can end up having severe injuries. Yeah.
Well, and also you were talking about draw sheets a lot. But there's also something to be talked about when it comes to the table itself or the pads on the table, maybe foam that we're using or whatever device we may be using underneath our patients. You also mentioned that we can't use shoulder blocks anymore. Is it called a shoulder block? Is that the right term to use?
Yeah, the shoulder bolsters or,
something. We can't use shoulder devices.
People still use them.
Yeah, I was in an operating room last week and I'm going, ding.
Wait a minute. So 2 questions. Well, 2 questions. One is, what is it about the shoulder bolster or device? Why can we not use that anymore? I think it's really important to explain why we can't. And also to talk about that surface we're putting our patients on and how that might contribute to friction or shear or skin damage beyond just the draw sheet they might be laying on, but the surface they're laying on for the entire procedure, right? So I know that's a twofold question and those are really different, but those are the things that come to mind as I'm listening to you talk that I would like to know more of the whys about.
Yeah. So, when we look at, like the skin and adipose elasticity, right? So when we go into Trendelenburg, one of the things I tell people is to use a normal pillow. A lot of people like to put foam or gel on their, on top of their foam pads or whatever. But when you start moving a patient in Trendelenburg, those 1 to 4 or 5 inches of movement depending on the patient's size that they are, right? I can glue you to a table, but your skin is going to pull a little bit until you stop, right? And our job is to create the friction and the chest pad to keep you from stopping. But what happens is that 1 to 2 to 4 inches of natural movement before they just stop. When you have something against the shoulder or the head and neck are still moving freely, but the shoulders are locked, that's where you increase the risk of brachial plexus injuries. And brachial plexus injuries, a lot of people just think it's because the head and neck move and the arms are stuck. That's partially true. There's actually 3 ways to get brachial plexus injuries. One is from direct compression up at the top, where your acromion is, your collarbone is, to where the shoulder is. The other part is along the side of the humerus. If that gets pushed in, or if it's pushed in too much and the patient's dragging down, that increases. Or if they're basically holding the arms really, really tight, but maybe don't have a chest pad. And we can talk about that here in a minute. And a chest strap, which is absurd. People don't use a chest pad or strap, but they'll sometimes tie their wrist to keep them from moving down. If you can imagine hanging someone from their wrist and their ankles. And we see that out in the field too. And people still do that kind of stuff, right?
I was taught to do that. Actually, that was 13 years ago, but still, I was taught to use those wrist straps, and it's terrifying.
And we even see things, again, we go in and we fix these situations, but we've been to places where, I'm not kidding you, where their systems weren't working that great for them because there was still migration, and they would put a footboard on top of the head and compress the head.
No way.
Absolutely.
Oh my goodness.
I would freak out.
The stuff we get called out to see from time to time whenever there's issues. And again, it's not meant to, and I'm not ever going to name anything, but we all as clinicians have to be aware that there are different cultures out there, and there are different facilities getting away with doing some of the things that we all know is probably not the safest. But again, they're doing it in a way that is meant to keep the patient safe because they don't have the right tools in place and they don't have the right training. And training is even more difficult these days because think of all the staff we have moving in and out of facilities all the time with travelers. And a lot of those folks can either bring in some good things or some bad things to a new institution and create even more chaos.
Well, and I think that's the entire reason why we're having this season is because people need to know why we do things. And it's not just the patient position isn't just important because we need to see the anatomy we're operating on, but what we do to put that patient in that position. And then for how long, like every single person in that room is going to be a part of putting that patient in the position that we need. And so it's important for the surge tech to understand. It's important for the circulator to understand anesthesia and the surgeon, for everyone to understand why all of these things are so important. And good grief, one of the things that you said that I would like to know more about is you said the chest pad. Can you talk a little bit more about that? I mean, I'm still having nightmares about wrist straps. But can you just speak to the importance of using a chest pad when we're securing that particular area of a patient's anatomy?
Yeah. So there's some folks out there who believe that, again, if you tape and put a bunch of tape across the chest, and we see that, we've seen the do it yourself and tape everywhere, which, is a bit annoying, but the more surface area you have across the chest is obviously can reduce, the functional residual capacity or, the lungs, chest wall's natural expansion, right? And that can increase risk with work of breathing and ventilation and stuff like that. But, using a smaller strap that's very stable, and we always use a pad with that so we don't have any pressure on top of the chest, right? You always want to put a pad on there instead of just a strap because as a patient moves down in that position, all of that pressure is going across the top of the chest, right? But we should still have lateral thoracic expansion. There's a video I put out there that, you can put in the link, and Melanie has seen it. But I basically use a fish tank with water in it, and I show everything that's happening in the lungs with gravity and loss of autoregulation. At the same time, it also represents everything of all the organs moving out of the way. But it also looks at shifts of adipose and skin elasticity as you start rotating the table and different things. The problem with not using the chest pad and chest strap, because people think it's going to impact the work of breathing, it's the degree of Trendelenburg that in, VQ mismatch and all the blood heading down in a gravity dependent spot of the lungs, because up here, because we've lost autoregulation, and then all the air goes to the least resistance up to the top. So you end up getting VQ mismatch, derangements and CO2, getting that out. And so it's that that's going to cause more problems than anything or just one strap you have across the chest. And to not have a chest strap across the chest, assuming that you're just head down, right? Again, if we're rotating our patients laterally, your patients
terrifying.
fall if you don't have something on there that's holding them in place. So just keeping something in a head down position. And then, with the head and shoulder systems, which is bad, right? That's why we don't use them, because if we didn't have a chest pad kind of slow down that little bit of roll and that movement that kept the head and neck moving this way while the shoulders are locked, you can see where you can end up having some issues associated with that.
I'm stuttering, actually. There's so much to think about. And I don't think any of us actually think about all the things we need to think about sometimes, or think about how it's all connected when we are putting our patients in these different positions, because it's another procedure. It's another case. It's another thing we do. And here we go. And there's so much that is compounded on everything that we do. And it seems like a lot of it is related to that depth and degree of the position of Trendelenburg that we do. And so educating and advocating for lesser degree, but also increasing people's understanding of what is going on with our patients. One of the reasons why we're having these conversations today, of course. And I hate to say that we are already out of time for this conversation. Every time we run out too fast. But so before we go, I want to give you, David, the opportunity to wrap up the conversation, provide some final thoughts or anything else that we didn't get to that you really just want to make sure everybody gets before we finish our conversation today. Go ahead.
Well, all I would say is look at your cultural practices and what you're doing and try to come up with something that balances the safety of everyone in the operating room. And sometimes that is going to require staff to look at other alternatives of positioning out there that's not on, say, for instance, your contract at your hospital. To me, that's the biggest impediment to our industry about adopting innovations and new processes. I can tell you for a fact that we're 10 to 20 years behind the innovation curve in the United States. We're ranked 11th in healthcare innovation despite our spend when compared to the rest of the world. And that freaks people a lot out. They don't believe that. But every conference we go to, and I'm sure you may be conditioned to ask, when you're looking at new products, the thing is, the first questions are, well, how much is it compared to something else? And or is it on contract, right? That's not value analysis, right? Value analysis is meant to have a product, even though it may be more expensive or even less expensive. If it's not on contract, most people have no idea of the new technologies that are out there. And so you have to fight for them and then fight for a comparative clinical value analysis process that looks at cost benefit, efficacy, and a balance of that safety. And so being an advocate for innovation is just as important as being an advocate for that patient, because we all want the right tools to do what we need to do.
Absolutely. David, as always, it has been a pleasure to talk to you and to learn from you. So thank you so much for joining us today.
Well, thank you. Thank you. And I'll get a syllabus over for you guys so folks can get on there and see all the research and everything that's out there.
Absolutely. I will attach it as a download on our social media write-up of this episode, and it will be included as a document download on the app. So if you don't have the First Case app, make sure you download it on either iPhone or Android. And David, thanks again. It's always a pleasure.
Thank you both. Melanie, Chris, thank you so much.
That was David Gomez, nurse anesthetist and CEO of Infinitus Medical. And Chris, we always learn so much whenever David takes the time to visit with us and come on the show and talk to us more about the dangers and the risks and the things that he sees in the field when we're talking about Trendelenburg positioning. But I think one thing that makes it so relatable when he talks is that he's so passionate about this topic, and he knows the research and he knows the information. And then he has those real life stories that just scare the pants off of you because you hear what he's seen, and it's just, okay, I've really got to get this right. I don't want to make a mistake or injure a patient. He's just really easy to relate to.
He really is. And I think we tell people all the time to advocate for your patient. And, there are 100 things going through your head while you're operating, but it's another layer that pay attention to the angle of Trendelenburg. And also when you're in those long, extensive cases where you are having to move your patient, speak up, say something. It's okay to say, hey, has this patient been in this position for a long time? Should we check the safety straps? Are we concerned about the patient's skin? It's okay to ask those questions because you never know what's going on underneath those drapes. And it is our responsibility to make sure that patient's okay. Because as you saw, there's some horror stories out there and you never want your name to be on that chart.
You don't. And you never want to have a patient that experiences those terrible effects because of the position they were in and the amount of time they were in that position. So as always, hopefully we have answered another why and explained the importance behind Trendelenburg positioning and the reasons why that we need to really be vigilant and always paying attention. So that is going to do it for today's episode and for this 6th episode of season 14. I genuinely hope that you are leaving this conversation with an increased awareness of the whys related to Trendelenburg positioning, and you've gained a deeper appreciation of the importance of positioning our patients correctly. So stay tuned. We've got more questions to answer and more whys to explain in this season. On behalf of Chris, myself, and our whole team, thanks for tuning in to First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.